Thank you very much for the invitation to discuss this important topic of advanced bladder cancer management. Bladder cancer has been an orphan tumor site, and for many years we did not have any effective treatment to treat these patients in advanced setting. But in the last few months, I would say, the landscape of treatment has completely changed, and that is because of the immunotherapy drugs. I'm going to discuss this in more detail, but let's just start now with the. Right, so my disclosures. So bladder cancer, most common histological type is transition cell carcinoma or urothelial carcinoma. It's the 8th most common cancer among the Saudi men. 193 cases reported in cancer registry, Saudi cancer registry in 2012, but it's not among the top 10 in female, only 52 cases in 2012. 5% of these patients present with the metastatic disease. 1-year survival is just merely 33% for stage 4 disease and 5-year survival of 10 to 15%. If the patient is a superficial early stage, non-muscle invasive, we just do TURBT followed by intravesical BCG. Those who have a muscle invasive disease, they have a neoadjuvant chemotherapy followed by cystectomy, and adjuvant chemotherapy can be offered to those patients who did not have neoadjuvant chemotherapy. Again, if the bladder preservation is the aim, then we can do chemoradiotherapy. And those patients who presented with metastatic disease, then platinum-based chemotherapy is standard treatment. So I mentioned that the landscape of this cancer treatment has changed because of the immunotherapeutic agent, but the immunotherapy is not new to bladder cancer. As you see from this picture, that in 1990 the first immunotherapeutic agent was BCG, which was approved for bladder cancer or urothelial carcinoma. But more recently, in 2016, 2017, we have atezolizumab, nivolumab, pembrolizumab, durvalumab, and avelumab, all approved for the treatment, and I'm going to discuss this one by one. So BCG was the first immunotherapeutic agent. How does it work? We don't know exactly how does it work, but most probably it's just the internalization of the BCG into urothelial or tumor cells, and that caused cytokine release and anti-tumor effect. Initially, it used to be just an induction of the BCG, which was not very effective, and most of the patients would relapse and would need a reinduction of the treatment. But in 2000, there was a trial where they have compared maintenance BCG versus no maintenance after induction. So you can see here in this graph, this thing is not very good, but anyhow, the relapse-free survival with the maintenance was significantly better, that is 77 months versus 36 months. And so this is more or less standard now after induction. Patient get BCG, intravesical BCG weekly for 3 weeks at 3 months, 6 months, and then every 6 months for 3 years. So those were for the early stage cancer, and now this is the landscape or NCCN guidelines for metastatic or advanced bladder cancer. Believe me, I presented the bladder cancer in April this year. This wasn't like that. Just in 6 months, things have changed. But still, the first-line treatment for metastatic disease is cisplatin-based chemotherapy. Gemcitabine cisplatin is the preferred one, but MVAC chemotherapy or dose-dense MVAC chemotherapy can be given. Those patients who are not eligible for cisplatin, and those are usually around half of our patients, I would say more than half of our patients cannot have cisplatin. Those patients, you can give either carboplatin with gemcitabine or can give immunotherapy. In first line, atezolizumab and pembrolizumab both are approved. The more interesting bit is the second line treatment. You can see the lower table. So the first 5 treatments, pembrolizumab, atezolizumab, nivolumab, durvalumab, avelumab, all immunotherapeutic agent. This has all changed. 5 months ago, it was not like that. So platinum-based chemotherapy is a standard first-line treatment. MVAC regimen is very well known for many, many years with the objective response rate of 50 to 70%. Complete response rate 15 to 20%, and median overall survival of 13 to 15 months with 2-year survival of 15 to 20%. Unfortunately, this is a very toxic regimen, and so it was compared with the gemcitabine cisplatin. The efficacy was similar, but less toxic, and that is why all over the world now gemcitabine cisplatin is preferred as compared to MVAC. But this is, of course, is one of the alternative treatment. As I mentioned, more than or nearly 50% of patients will not be eligible. In fact, in our setting, I've seen nearly 70–80% patients are not eligible for cisplatin. So it's a good news that we have some other drugs now. So in first line, those patients who are ineligible, we can give atezolizumab or pembrolizumab, or all the 5 immunotherapeutic agents can be given in second line. So first of all, I'll start with atezolizumab, which is a PD-L1 inhibitor. The way it works here in this cartoon, you can see the T cells and the tumor cells. When the T cells and the tumor cells interact through the PD-1 receptors and B7 receptors and PD ligand 1, the T cells get activated, but at the same time they send inhibitory signals to inhibit the T cell, which we don't want. We want the T cells to be activated to do the cancer killing. And so the benefit of using PD-L1 inhibitor here, if you can see here, it inhibits both PD-1 and PD-7-1. So, so the inhibitory signals are stop going through them, and so T cells remain active. At the same time, it does not block the PD-L2 and PD-1 interaction, and that theoretically should prevent or reduce the risk of immune-related adverse events. So atezolizumab works with targeting the PD-L1 on tumor cells and immune cells within the tumor microenvironment and reactivates T cells. It provides dual blockade of PD-1 and B7-1 receptors for enhanced T cell activation and propagation. But it leaves the interaction between PD-L2 and PD-1, so which potentially preserving peripheral immune homeostasis. It has been tested in phase 1 study, and it was positive. You can see here in those patients who have a high PD-L1 expression, their overall the objective response rate. Oh, thank you. Okay, so this you can see it now. Okay, so you can see here those patients who have a higher PD-L1 expression, the response rate was 39% as compared to those who does not have PD-L1 expression, 12%. So the same is with overall survival was better with atezolizumab and higher PD-L1 expression. Phase 2 study IMvigor 210, that was the study which led to approval of this drug. I'm going to discuss this in more detail later on. But first of all, a phase 3 study of atezolizumab called IMvigor 211 study, which has randomized patients on one-to-one basis versus chemotherapy of the investigator choice venflunine, docetaxel, and paclitaxel. Treatment continued till progression or loss of clinical benefit. Primary endpoint was overall survival, and the secondary endpoints were objective response rate, progression-free survival, and duration of response. Study was unfortunately negative. You can see here the graphs, survival curves. It showed the median overall survival of 11.1 versus 10.6. So chemotherapy and atezolizumab median overall survival was not much different, with hazard ratio of 0.87. One thing which you might notice here is the separation of the curve started at 10 to 11 months. So we might see the survival benefit with the immunotherapy later on, but at the study cutoff point, it was negative. Again, this was the previous slide was for those who had PD-L1 expression, but this is for the whole population. The study is negative again. There was no benefit. The median overall survival was 8.9 versus 8.2 months, hazard ratio of 0.87. Objective response rate results are negative again. The objective response rate was similar between atezolizumab and chemotherapy, both arms. But the positive side of the positive results in this study were duration of response in intention to treat patients. You can see here those patients with atezolizumab had 21.7 months of median duration of response, while chemotherapy 7.4 months. And 63% of patients in atezolizumab arm and 21% of patients in chemotherapy arm had ongoing responses at the data cutoff point. In subgroup analysis, almost all group of patients favored atezolizumab as compared to chemotherapy, except those who had a renal pelvis disease. Again, they have done further subgroup analysis with the different chemotherapeutic agents, and is just with the taxanes, those who had with the intention to treat with taxane, the survival benefits was better with a hazard ratio of 0.73, but not with vinflunine or other treatments, other chemotherapy agents. Then MVigor 210 was a phase 2 study. This trial led to approval of this drug, not the phase 3 study. There were two cohorts. Cohort 1 was those in first-line patient, those who were ineligible for cisplatin, and cohort 2 were those who had previously had platinum-based chemotherapy. They have defined the PDL1 expression as less than 1%, 1 to 5%, and more than 5%. Objective response rate was the primary endpoint of the study. Overall group 16%. Those who had higher PDL1 expression, it was 28%, as compared to those who have low or no PDL1 expression, it was 10%. The median duration of response was not reached at 21 months, but 65% patient had ongoing responses at the data cutoff point. So the interesting bit here, you can see here, these yellow dots are the initial responses, were very quick. Within 2 months, these patient response. These blue lines and white lines mean complete or partial responses. And those patient response, most of those patients you can see have an ongoing responses. These green arrow mean they are still responding to the treatment. Overall, overall survival in different groups, you can see here those patients who have a higher PDL1 expression, the median overall survival was 11.9 months, as compared to 7.9 for the whole group, or 6.7 for PDL1 negative. Same as with 12 months overall survival, 50% in the high PDL1 group, as compared to all group 37 and 31 in the negative group. So those patients who have higher PDL1 expression, the immunotherapeutic agent is better in this trial. Toxicity-wise, grade 3, grade 4 treatment-related toxicity was seen in 16%, which is very much standard for any immunotherapeutic agent. And the median treatment duration was 12 weeks with median number of doses, 5. There were no treatment-related deaths recorded in this study. Again, the complete responses, you can see according to the PDL1 expression, 14% in those patients who have higher PDL1 expression, as compared to only 2% who did not have any PDL1. Same as with the objective response rate, which we have discussed in the previous slide. So that was cohort 2. Cohort 2 was strongly positive, and cohort 2 patients were those who had previous platinum-based chemotherapy. So it was approved in second line after platinum-based chemotherapy. Now, cohort 1 in the same trial, MVigor 210, were those patients, those who were ineligible for cisplatin in a first line. Most of the patients had renal impairment, that's why they could not get cisplatin. There were patients who had deafness, who had peripheral neuropathy, and poor performance status of performance status 2, ECOG performance status 2 were included in the study. Objective response rate was 23%, and responses were seen throughout the group, either regardless of the PDL1 expression. 23 patients who responded, 22 of them were had ongoing responses, but median duration of response was not reached. Median follow-up was 8.5 months, and median treatment duration was 15 weeks. So overall, from this study, atezolizumab in first line was well tolerated. Treatment-related all-grade adverse events were 64%. There was one grade 5 adverse event, and 4.2% of the patient discontinued treatment because of these adverse events. So atezolizumab was approved in first-line cisplatin ineligible patient and second-line patient who had cisplatin before because of the phase 2 trial, but not because of the phase 3 trial. Then pembrolizumab is a PD-1 inhibitor. This is the only trial in bladder cancer which has grade 1 evidence. So the phase 3 trial called Keynote 045, which has randomized patient in pembrolizumab versus chemotherapy, and chemotherapy investigators used were paclitaxel, docetaxel, venflunine, and the treatment continued for 24 months, or either they achieve complete response or progressive disease or withdrawal of consent. Again, primary endpoints were overall survival, progression-free survival, with secondary endpoint of objective response rate. It is a positive study. You can see here in those patients who have high PD-L1 expression, the median overall survival was 8 months versus 5.2, with a hazard ratio of 0.57. 1-year survival, again, in favor of pembrolizumab, 39.8 versus 26.9%. That was for the high PD-L1 expression, but this survival curve is for the overall group. Again, pembrolizumab 10.3 versus 7.4 median overall survival in favor of pembrolizumab. 1-year survival, again positive, 43.9 and versus 30.7 in favor of pembrolizumab. Objective response, the blue bar is for pembrolizumab, while the orange and yellow one is for chemotherapy. So objective response rate in the total population was 21% as compared to 11%. Again, it is favoring pembrolizumab. Then in those patients who have high PD-L1 expression, it is favoring pembrolizumab. So regardless of the PD-L1 expression, the patient favors pembrolizumab. Toxicity-wise, this is very interesting. You can see here almost all the toxicity noted in the trial were more with chemotherapy as compared to the pembrolizumab immunotherapy, except pruritus. You can see here, which was seen more in pembrolizumab. This was in a second-line setting, phase 3 trial, and now we have a phase 2 trial called Keynote 052 in a first-line setting in cisplatin ineligible patient. Pembrolizumab 200 milligram every 3 weeks were given, single arm, treated up to 24 months or until complete response, progressive disease or side effects. Primary endpoint, objective response rate. Secondary endpoint, duration of response, overall survival, progression-free survival was seen. So after 100 patients, they have analyzed the data. You can see here, objective response rate is 24%, complete response is 6%, partial response is 18%. Drug-related adverse event was 67%, but grade 3, grade 4 drug-related events 16%, more or less similar to any other drugs. So median follow-up at 8 months was 8 months, and median time to response was 2 months, pretty much similar to other immunotherapeutic agents. Around 2 months, these patients respond, and those respond usually have prolonged response. You can see here, more than 6 months, 83% of the patient had an ongoing response at 6 months or more than 6 months. Again, the same thing for the PD-L1 expression. So this group is with the PD-L1 expression of more than 10%. This is 1 to 10, and this one is less than 1%. So those patients who have more than 10% have a slightly better objective response rate as compared to those who have a less than 10%. But overall, the treatment works in all the patients. Third immunotherapeutic agent is nivolumab, which is a PD-1 inhibitor. Again, a single-arm study called Checkmate 275. It's a phase 2 trial, and that led to approval of this drug. Nivolumab was used 3 milligram per kilogram every 2 weeks. Treatment was continued until progressive disease or clinical deterioration. Primary endpoint, objective response rate. Secondary endpoint, progression-free survival, overall survival, and time to response. Positive study again, objective response rate was 19.6%, complete response is 2%. Again, objective response rate for the PD-L1 expression was positive in all the groups. For more than 5% was slightly higher. You can see at 28.4%, but even for those which were less than 1%, there was a response seen. Time to response, again, similar. Around 2 months, most of the chemotherapeutic agents start responding, and duration of response, immediate duration of response is not yet reached. Any grade toxicity, 64%. Grade 3, grade 4 toxicity, similar to other drugs, 17.8%. The most common grade 3, grade 4 treatment-related toxicity was fatigue, diarrhea, and asthenia. Durvalumab has been approved very recently, and it's an anti-PD-L1 antibody. It was a phase 1, phase 2 dose escalation study, and they have reported their results according to a PD-L1 status. So for any patient, 31% response rate was seen with 48% 12 months disease control rate. For tumor cells, those patients who have a positive PD-L1 have a better response of 47% versus negative 22%. Immune cells, again, those who have a PD-L1 positive disease have a better response rate of 56 versus 13%. And in those patients who have more than 25% of the PD-L1 expression, you can see here the big difference, 46% versus 0%. So this was presented in ASCO 2016, but the drug was approved by FDA in 2017 when there were 182 patients recruited at that time. Objective response rate reported as 17%. Median duration of response has not reached yet, but objective response rate was 26%, 26.3% in high PD-L1 group as compared to 4.1 in those patients who have low or negative disease. And because of that drug approval, along with that, FDA has approved testing of PD-L1 before we administer this drug. Serious adverse effect was seen in 43% of the patient. The last among all the immunotherapeutic agent in second line or subsequent line is Evolumab. Very recently it has been approved. It's a PD-L1 inhibitor, and it was approved on basis of phase 1 trial. And this is a conditional approval. It's a single-arm study of 242 patients whose disease progressed after platinum therapy previously. So objective response rate who has had followed up for 13 weeks was 13%. And 16% in those who were followed up for 6 months. Median time to response was 2 months. This is pretty much standard now for any immunotherapeutic agent, 2 months. And median response duration had not been reached yet, but they're estimating it to be around 1.4 to 17.4 months. This drug is slightly more toxic than any other immunotherapeutic agent. You can see here 6% of the patient died in the trial. Serious adverse events were reported in 41% of the patients, and the main concern is infusion-related reaction. This was quite commonly seen, which was not seen in other immunotherapeutic agent, and that's why they're saying the recommended dose for Evolumab is 10 milligram per kilogram intravenously, but before that we have to pre-medicate the patient with antihistamine and acetaminophen at least for the first 4 doses of Evolumab. So just to summarize, now we have in first-line setting atezolizumab, we have pembrolizumab, and second-line setting we have atezolizumab, nivolumab, durvalumab, pembrolizumab, Evolumab. So being an oncologist, now we need to think which is the best drug for our patient and how to decide which drug should we be giving. We have a choice of drugs. It is very difficult to think, but just to summarize all the trial, I've said this is by no means comparison of the trial, but I have just tried to summarize what I have explained to you in today's talk. This is my last slide anyhow. So you can see we have 2 phase 3 trials. One is that of atezolizumab and one is that of pembrolizumab. And the atezolizumab phase 3 trial, the primary endpoint was not met, but as I mentioned, the strange thing was the response was seen only after 10 months and the curves started to separate. So you might see that survival benefit is there. In pembrolizumab, the survival benefit was there and it is a positive trial. The highest number of patients recruited in the trial was that of phase 3 trial. You can see here 542 patient, keynote 045 for pembrolizumab. Apart from that, objective response rate more or less similar in all the trials. You can see here discontinuation rate more or less similar between 1% to 5-6%. Grade 3, grade 4 toxicity more or less similar, but with durvalumab it was a bit higher, and with Evolumab we've said there were 6% deaths happened. Again, any grade toxicity more or less similar. So I cannot from myself recommend any specific drugs, but this is what data we have. And we hope in the future we will have enough experience or we will have a direct comparison of these drugs and we will be able to choose better for our patient. Thank you very much.